Hello, everyone. Good morning, good afternoon, good evening, wherever you are in the world. Welcome to Meet Menaca, episode 58. So today we are going to be speaking about pain management with the Dr. Naveen Rajadurai. Dr. Naveen Rajadurai is a consultant musculoskeletal radiologist, and he's into diagnostic and intervention in KPJ Damansara Specialist Hospital. He graduated from the University Saints Malaysia in 2004 before obtaining his master's in radiology from University Malaysia in 2012 and furthering his subspecialty training as a fellow in musculoskeletal radiology under the Ministry of Health, Malaysia, training in diagnostic musculoskeletal disorders, predominantly sport injury imaging, bone oncology, and rheumatological disorders. His interest then gravitated towards musculoskeletal intervention radiology, where he trained in Hospital Sungai Buloh performing interventional procedures related to pain control, therapeutic, bone oncology, and sports injury intervention. He also completed a stint in AORN, Cadorelli, Naples, Italy in 2016, training in spine intervention, predominantly vertebroplasty, kyphoplasty, and ozone intervertebral disc therapy, with an attachment in SS Trinita Cagliari, Sardegna, Italy, performing radiofrequency treatment for spinal pain. Dr. Naveen then further went to advance his knowledge with an internship to Hospital New Civil, Strasbourg, France, where he was fortunate to train and perform cryoablation of bone and soft tissue tumors via CT and MRI guidance. He's currently Vice President of College of Radiology, Vice President for Malaysia Society of Interventional Radiology, as well as life member of Malaysian Society Interventional Pain Practitioners. A very warm welcome to you, Dr. Naveen. Thank you so much for joining us.
Thank you. Thank you for the invitation. It's a pleasure to come in. Right.
Yeah, thank you so much. So firstly, even when I got to know, I'm sure on many people's mind, they're thinking, Dr. Naveen is a radiologist. What makes him want to speak about musculoskeletal intervention or, even pain management? So what is your role and why are you interested in pain management, Naveen?
Okay, so yeah, thank you, Menaca. So actually, so my training is actually as a musculoskeletal radiologist. And so I actually diagnose a lot of patients who have pain. Mostly when I started my career, we were doing a lot of, I actually do a lot of imaging for the National Sports Institute, all the national athletes, as well as the Football Association of Malaysia. So when we started doing all these diagnostic evaluation on imaging for these patients, I sort of started correlating their clinical problems, especially their pain problems with the imaging. And that is the advantage being a musculoskeletal radiologist. I can see the imaging findings and correlate that with the patient's pain and treat the adequate problem that the patient is facing. I think this is something that probably the other clinicians may not have that advantage of the imaging knowledge. I have the imaging knowledge, and based on that, I actually treat the patient and thoroughly try to clear their pain issues, and targeted pain therapy for the pain that they're experiencing. And so I've been doing that already for the past 10 years in my center. But in Malaysia, our pain society is a multidisciplinary body. So we have spine surgeons, we have rheumatologists, we have interventional radiologists, we have also some neurosurgeons who are doing these pain intervention procedures. So I guess I'm just one of the ingredients in the big cake that actually treats pain, and I have my strengths, and so do the other surgeons and all, and we try and complement each other to wholeheartedly treat the patient's pain problems, and diagnose, and as well as treat the patient as inclusively and as completely as possible.
Sure. I think it's the secret is in holistic management, isn't it? And that is where the multidisciplinary team definitely comes in. And I think it really works. And I would say you're the piece in the puzzle. I'm sure you're a major piece in the puzzle, though. So,
Thank you. You're being very kind. Yeah.
good
So we correct. Right.
good to have you there. So, usually when of course, we have facial pain, we have pain, if you have body, I guess you are, prone for pain. But however, we we mostly hear about neck pain, back pain, and definitely as a dentist, I know a lot of certain occupations, we have pains as well and repetitive. So firstly, before we go into any of those things, if you have neck pain or back pain, when do you think is the right time to seek treatment or advice?
So that's a very good question. So actually, a lot of people do experience pain, a neck pain or a back pain, regularly. You probably have a normal episode once in a year or twice in a year. And usually it happens only for about a couple of days or even for a few hours, and then it goes away. And they say that the studies say that once in a lifetime, you will have one episode of very severe pain needing to go and see a doctor. And usually the alarming sign or the alarm bells that should be raised for a person or patient who's having neck pain or back pain is when the pain persists for a significant amount of time, being at least a week, and doesn't get better with if you put on an ice pack, if you put on all the hot water bottles, if you're taking some medication, pain medication, and you see that the pain is constant. And the most important thing is that when the patient or the complainant starts having radicular pain is shooting pain down your arm for the neck pain, and for your lower back pain, if you have shooting pain going down to your leg, then you should immediately go and seek treatment in a hospital to see a doctor and get yourself diagnosed, because these kind of pains usually do not do not respond only via medication. And we have to look at thinking that the pain source would be probably a slip disc or cervical spondylosis. And for that, you may need further treatment on top of whatever oral medication that you're getting.
Yeah. So you mentioned it's if it lasts for more than a week and if it radiates towards the arm or a leg. What about the frequency of it? You said once or twice is okay. So when they have to think, okay, this is now frequent enough for them to go and see a specialist.
Yeah. So if you get it one episode and you think you just have some numbness going down your leg, and then it goes off within a few hours, then it's fine. But what the patient who's having a slip disc of the neck or of the lower back actually experiences is that they usually present either with low back pain or just a tightness of the back. And this progressively worsens. The first episode would have been just some low back pain, then gets better. And then they get a more severe back pain on the second episode, maybe after a few months. And it could be sometimes just after a trivial activity, maybe just some gardening at home. And then suddenly you have this severe back pain that you have. And when the pain suddenly migrates or progresses to a shooting pain down your leg, and it's significant, you'll feel like electrical shock going down your leg, and you have that kind of symptoms, then you should actually come and seek treatment in a hospital, and you probably need some advanced imaging. So an X-ray would probably be where we start off with, but it will most probably, if you already have some pain shooting down your leg or your arm, you probably need an MRI to further confirm the diagnosis of a slip disc.
Sure. Thank you, Nat. So I think just to reiterate, as I understand, is it's first of all the frequency, then whether it is progressive, and also it's not proportional to the activity you are having, the which started it, and also then of course where it radiates. All these symptoms should make you think might be it's high time for you to get medical advice, right?
Correct. That's correct.
Sure. Thank you so much. I know these days, of course, the first question people always worry about, or people have even asked me, is do all the neck and back pain, can be managed conservatively, or do they need a surgery? That is a big question, which is on everyone's mind usually. So what is your answer as an expert?
I think that's a very good question again. So the thing is that I think a lot of people have a lot of anxiety or a lot of preconception when they come for pain to the hospital. They are going to be operated on immediately, and I always tell them that operation is only one of the options for treatments of pain. And usually we will start by diagnosing the source of your pain. And sometimes pain can be just a simple thing as just a muscular pain, being just a spasm of the muscle, or it can be disc impinging onto the nerve or pressing onto one of your nerves going down. Then the treatment would probably be different. And if then also it also depends on the size of the disc bulge, whether it's a small disc bulge and whether it's a larger disc bulge. And okay, God forbid, and sometimes the pain could be even a more sinister presentation of a bone tumor or a metastasis from a cancer, you see. So for a general person, it can be quite difficult for you to differentiate it. So you probably, like I said, when you have the pain that is persisting, getting more severe, you probably need to come to the hospital. And based on the imaging, we need to, to confirm what is the source of the pain. So like I said, if it's just a minor pain, if it's a, with spasm and things like that, usually most patients respond with some physiotherapy, some stretching exercises, some heat therapy, ultrasound therapy, TENS, and a few other different modalities that we have to treat just the pain. And for slip disc, there can be two branches. So if it's a very minor slip disc, this is where I come in. I'm able to put in a needle into the patient's intervertebral disc, and via this needle, we are able to give either a electrical pulse, we call it, or a radio frequency pulse to the disc, and to shrink the disc via a minimally invasive approach. And usually these procedures, I do it most of the time under sedation. It's most of the time a daycare procedure. Patient doesn't have to go through general anesthesia. And usually a bulk of my patients actually go back the same day, and only in a few instances, I do keep them overnight for patients who have other medical problems, or when the patient's pain initially was very severe. And that's the only instance where they will go back the next day. And I think among the patients who have slip disc that I've encountered, maybe only about 20 to 30% of them would actually need proper surgery to evacuate the patient's bulge disc that is actually pressing onto the nerve. So a lot of my patients actually respond to conservative management, being that just sometimes even when they come and see me, expecting me to do an injection for them or expecting me to do this thing. So I'm sometimes sad to disappoint them by telling them that, the pain is not severe enough. I think just by some stretching exercises, you will get better. Maybe give it some time. But when the pain is severe enough, if it's debilitating, if it's causing a lot of discomfort and it's impeding your normal activity, you feel that you cannot go. And I see sometimes some element of depression actually setting into the patient because they are unable to control their pain, and the pain is affecting their whole family. The family members are also affected. The caretakers are also affected. And that is when I will sometimes not follow my exact advice and intervene earlier on, because I can see that the repercussions of not intervening is affecting everybody around the person, and in these instances, then probably doing a minimally invasive treatment earlier rather than later will actually prevent all this from happening.
Sure. Thank you. So for a couple of things for people who are not from the medical background is the
right.
intervertebral disc is the spine is covered by, you're the expert, but yeah. I have very limited knowledge, but the spine is covered by small bones, which is called the vertebrae, and there are discs in between the vertebrae. So that is when he said, when Dr. Naveen said that's what he meant. So that for people who don't understand or a bit confused, that's what it is.
Yeah.
And so that's right, isn't it? Because I think sometimes people go to doctors, particularly specialists, thinking something is going to be done then and there, and they are going to sort out the problem. And it's not a miracle all the time. And sometimes you have to, it's a long haul treatment and management. You have to just wait and see. And I think any surgery should be the last resort. Is that okay? Is that correct, Dr. Naveen?
Yeah, correct. So in regards to treating spine pain now, we are actually reserving surgery as the final and last resort, because and even the surgeons are actually receptive to this idea and actually are encouraging any sort of minimally invasive treatment first before finally deciding on operating on a patient's spine. Because once you change the biomechanics or the movement of the spine by fixing or doing surgery on the patient, there a lot of other problems can also occur, scarring and post-operative complications and things like that. So everybody is actually in the same page now, saying that we probably try all these other treatments first. And probably that's where I come in to help to provide this option of treatments for patients.
Sure. So thank you so much for enlightening us, because every back pain or every neck pain doesn't need a surgery. However, some of them do. So when do you then decide? You've already mentioned one, because it's not only causing a lot of trauma or psychological distress for the patient, and but also causing distress to the family. But other than that, when would you say, yes, now is the time we really do need a surgery then?
Okay, so for patients who have slip disc, so if the slip disc is causing just pain radiating to the arm, and on the MRI, the disc is just a minor disc bulge and only touching onto the nerves or pressing onto the nerve, then usually these patients don't really need surgery as their first option. They can try some minimally invasive treatments. Probably the ones who have really severe bulging of the disc pressing onto the nerves, and also if it's involving multiple levels. Unfortunate for some patients, you have not only one level of slip disc, you have maybe 4 or 5 levels of slip disc, and the discs are severe in all these levels, then maybe you look at selecting one of the most severe levels first and think about doing surgery for these patients, And the other instance would be like for patients who have tumors in the spine. So if it's a small tumor, I actually can treat the patient minimally invasive. So what I do, I put in a needle into the tumor and freeze the tumor. So when I said that we give cryoablation, it means we make an ice ball and freeze the tumor. And basically, once you freeze the tumor, you kill the tumor. And these treatments are available here, and are one of the options that we can give patients when the tumor is quite well controlled. It has not spread outside of the bone into the adjacent soft tissue, and hasn't actually invaded any of the vessels next to the bones or into the nerves, you see. And of course, when all these happens, then probably surgery would be the better option for the patient. And the other thing is that in some instances, patients can develop fractures because the tumor has already caused the bone to be soft, and a trivial sort of force can actually accentuate a fracture that the patient can develop. And in that instances, if it's a minor fracture also, I still have some role in putting in a needle into the vertebrae and injecting cement to fix the bone, the fracture. But in other instances, probably the patient will need open surgery and putting in a screw and a rod to stabilize the spine. So, so it can be very daunting at times to decide when surgery would be the option. The other extreme of patient I see is that some of them who I do my minimally invasive treatment, I have to admit that about 10% of them do not respond even after the treatment. And in those instances, when they've already undergone my treatment, and sad to say that they do not respond, then I tell them probably you need to explore option of undergoing surgery, because you probably did not respond to minimally invasive treatment. So these are the instances where I see the patient needing surgery. But apart from that, the practice now is to try as much as possible to do some minimally invasive treatments first before going to do surgery.
That is really good to know, because I think the moment people hear the word surgery, of course, all sorts of things come to mind and people are scared, including myself. So I think it is good for everyone to know. First, they will try their best not to non-invasive procedures, and then minimally invasive. Only if all this fails, then they will be having a surgery as such, a major surgical procedure. So at least I hope it will want people to then go and consult and explore all these options without getting scared of the surgery as such. So thank you, Dr. Naveen, for that. I know you mentioned a couple of them, that there are minimally invasive treatment options for the neck and back pain. Do you treat any other pain than the neck and back?
Okay, so again, I mean, the bulk of my patients who come in for pain is usually related to their neck or lower back pain, and sometimes I do treat other pains. So recently, I have a lot of patients having, like you say, cancer patients that come in who have tumors that have gone to their spine. And sometimes it's only one tumor there in the spine and the patient is relatively well otherwise. So we, like I said, we freeze the tumor in the spine, get rid of that one lesion, and patient usually has no other spread of disease anywhere else. And then the patient actually survives and continues the chemo, and they actually respond quite well after that and have a good quality of life after their procedure. So these are one instance of patients where they respond to my treatment. The other one being cancer pain. So there are some cancers that actually invade into the nerves. These are actually end stage cancer patients. The goal of treatment is not to cure the patient's cancer, but however to make the patient comfortable in the last few months or weeks of their lives. And in that instance, I can provide, the option that I can give the patient is that putting in a needle via the CT scan or MRI into the nerve that is being infiltrated by the tumor, causing the patient a lot of pain, and injecting some medication. I can inject some alcohol, they call it a pure alcohol, to actually dissolve the tumor around the nerve that is causing patients pain, and give some anesthetic medication around that nerve to actually relieve the patient's pain, at least until the final days of their life. And their family, and especially the patient, is very grateful for that comfort that you can provide them during those last few days of their lives. The others, I do treat a lot of sports injuries. So I have sportsmen who come to my hospital and seek treatment. Those with some tendon tears and who have ligament tears in their joints, whether they're ankle, footballers, badminton players, divers, and all, who also have these treatments. And I have the knowledge as well as the option of treating them by again using my ultrasound or CT scan to place a needle there, inject some medication. Sometimes I inject PRP or plasma-rich platelet to help the recovery of the tendons and the ligaments. And a lot of patients for acute injuries actually respond quite well to them. My other ventures of pain, also include, I treat a lot of craniofacial pain, patients with dental pain actually. So I have a lot of dentists sending me patients with trigeminal neuralgia. So it is actually a nerve that is that originates in your, near your jaw. Yes, and there's 3 branches. We have 3 branches, one going up to your eye, one going to your upper lip, and also one to your mandible or your jaw. And sometimes this disease is very difficult to diagnose. I think and the things that they usually present to my dental colleagues, and and they are also at a loss. So first thing they do is remove the patient's wisdom tooth, thinking that because there's a lot of correlation between the wisdom tooth and this pain. And when the pain does not get better, then they say, oh, it probably is trigeminal neuralgia. And sometimes the medication that prescribed for this trigeminal neuralgia can cause the patient to be very drowsy, very unproductive at work. And especially if they are a young person going to work, they tend to default their medication because they say they cannot function. And they said, I feel so drowsy, I can't wake up in the morning. So although I'm in pain, but it's affecting my performance at work. And of course, a lot of patients are okay with taking the medication and they are fine. They have this transient period where all these symptoms do get better, but some of them who need high doses of this medication, then the pain is not controlled. So what I can actually provide is I do an injection for them around the trigeminal nerve. I do radio frequency of the nerve, and quite a few of them have quite good response to these these to these treatments, and they don't mind coming back later for a follow-up injection or a radiofrequency treatment, because I tell them usually the literature also says that the treatment only lasts between 18 months to 3 years. And so they are already mentally prepared to come back for their treatment, knowing that it is not a completely curative treatment, and after that, with their medication, they are actually very much normalize their lifestyle after that, and it helps with their normal activity after that. And they're very thankful, actually, the patients, very, very thankful.
Thank you so much. Today is the day I'm going to stand up for the profession,
Right.
because I don't think we take out the wisdom teeth because trigeminal neuralgia, to be honest, it presents very differently, because even people can brush their teeth and the pain can
Correct.
start.
Correct.
And any trigger, sensation or touch can trigger. So I don't understand why people take the wisdom teeth.
I think because when it's abutting the inferior alveolar nerve, that is when people think that it is this thing. So a lot of people are biased by the decision, or I think sometimes in some instances, some dentists are probably helpless. They don't know what to do, and they don't know where the avenue to get the further treatment. And by the time, actually, how I engaged my patients were through my oral maxillofacial surgeon. So when he had a few patients like this, and then he said, "Isn't I don't know what to do." And then when they come to me and they get better. And that's how he started sending more and more patients that he gets referral from the general dentist who come and send to him, and expecting him to do something, some surgery. And he says, "No, I don't think this is the treatment for the patient. You should be doing other treatments, because trigeminal neuralgia, the treatment is different, And like I said, so I don't blame all dentists, but I think some of them have, because they're desperate, due to desperation, they want to do something for the patient, and the patients, in some instances it works. I don't know. So probably the diagnosis was not right at the beginning, So
sure.
It can be very confusing also, in trigeminal. Yeah.
Well, it's history taking, is it? That's what it is.
Yes, correct.
Yeah, sure. Thank you. So you did touch upon the trigeminal neuralgia, and I actually know someone who used to come on this particular platform and ask questions. So I'm going to ask him to go and watch this video afterwards. So on his behalf, I will ask the question. Do you still give anti-epileptic drug?
Yes, I did. Yes, I did. I still give the patient the Tegretol and carbamazepine and Neurontin, and some Lyrica for the patient. So usually, even after treatment, the thing is that when they are already on quite a significant dose of carbamazepine, you cannot withdraw the medication immediately. Patient gets a very sudden rebound attack after you do that. So you have to progressively taper the carbamazepine down. From probably to reduce the dose first, and then reduce the frequency, and then after that try and reduce it to alternate days, and then only finally taper the medication off. So usually my treatment plan is that after I've done my treatment, I usually tell the patient, we will continue your current dose for a week, and then I will cut down your medication. And for those who follow that regime, they usually actually, I've actually weaned them off their medication, at least for a significant amount of time. But I tell them, even if I can reduce your dose by half, definitely the side effects of the medication would be much less than what they're experiencing.
Sure. Thank you so much. And I know another regular participant has a shoulder pain. I'm sure he might be waiting to ask the question. So what about shoulder pain? Do you treat them or do you manage them?
Yeah, so the source of the shoulder pain may be just a tendon tear. So if it's a minor tendon tear, sometimes the sports surgeon, it has no reason for them to operate and actually, to operate on the tendon. So usually an injection into the shoulder or around the tendon will actually reduce a lot of the patient's symptoms. Sometimes the patient has a bursitis. So a bursa is actually a fluid pouch that is just above your tendon that can get inflamed because of impingement, because when there's a bone from your shoulder joint pressing onto the tendon, it causes a lot of irritation, and this fluid-filled pouch becomes inflamed and swells up with fluid. And then once it's swelled with fluid, it's called a bursitis. Because it's inflamed, and it can cause a lot of pain for the patient. So in bursitis, we can do an ultrasound guided injection into the bursa, where we inject a bit of medication, steroid, and things like that to reduce the inflammation. And a lot of patients have almost instantaneous relief actually after the injection. So shoulder pain is something that I've been treating for some time. I work quite closely with some of my shoulder surgeons in my hospital, where they also are not keen to do surgery unless it is a significant tear and involves a very young patient who they think that that the recovery is good and is not going to cause them any problems in the future. Then we do discuss the case and decide how to go about step by step treating the patient.
Sure. I think one thing we have to be very clear is I know that particularly, thank you so much. It was very comprehensive, explanation for all the different pains. Going back to cancer, because it just occurred to me, we were talking about cancer and you do treat, but I think it's important for people to understand you don't treat, I guess that's my understanding, you don't manage the cancer itself, you manage the pain and you manage the effects of cancer. Am I correct? Or
correct? So usually so my referrals come from the oncologist. So when the oncologist comes, the diagnosis is already established by the oncologist. And then when there is a bone element to the disease or a muscle element or there's a nerve element to the disease, then I get the referral. And then we work together, either deciding to cure the patient, as in to target the tumor to shrink it entirely, or just control the patient's pain, knowing that the patient's outcome is going to be poor already at the beginning, at the time of diagnosis, that the patient's already terminal. Then we only targeted, we manage the patient's targeted treatment just to adhere to the source of the patient's pain and not to cure the patient of the disease. So, so that is one of the principles of interventional radiology in musculoskeletal system. You have to decide at the early onset whether you want to do a curative treatment or a palliative treatment, because expectations are different. How aggressive you are to treat the patient is also going to be different in that instance.
Sure. Yeah. Palliative treatment for people who don't use this terminology very often is for like end of life care kind of thing. Like, they have come to a position it can't be cured, but service providers are going to make them feel as comfortable as they can.
Correct. Exactly.
Thank you so much, Naveen. So, the other thing, of course, a lot of people want to know, particularly older people or people, who are living on their own, what would perhaps want to know is that pain management at that stage, do you always have to be hospitalized, or is it like outpatient, because people who are elderly and dependent and living on their own, I guess the care is not as simple as other people. So, what would you say to them?
Okay, so thank you for the question. So I've treated patients, at both extremes of ages. So I treat very young patients. My youngest patient was 16 years old, rugby player who had a slip disc, and my oldest patient was 95 and had a very severe neck pain because of a slip disc in the neck. So you call it cervical spondylosis with some nerve impingement. So the disc was pressing onto the nerve and the patient was having pain. So in that instances, in the 95-year-old patient, definitely because he had a lot of other medical problems with some diabetes, heart problems, a lot, and he was a lot also on some blood thinners. So when the patient is quite complicated like that, I will probably need to admit them just overnight. The procedure is done without general anesthesia, usually with some sedation, and I just get my anesthetist just to come in, just to give the sedation and manage all the oxygenation, because I'm concentrating on the procedure. But on a normal well patient, which is about 90%, 85% of my patients, most of the procedures are done as a daycare. Let me just illustrate to you a normal patient that comes to see me. When they come to my clinic, they see me, and then we do the MRI and we decide that we want to do a procedure. I usually tell them, after that, you can go back home. We will schedule it on an elective day. So my usual advice is probably have a light breakfast at 6 a.m. I see you at about 8:30 a.m. in the hospital. We'll do a blood test at about 9. Blood results are out at 10 o'clock. We do the procedure at 10:30. 11 o'clock, finish the procedure. So usually I give some sedation. So we reverse the sedation. By 12 o'clock, patient is fully conscious. I tell them you can go back and have lunch at home. So that is usually the normal patient that comes to me. Of course, in some circumstances, in elderly patients, because you want to be a bit more cautious, they are on some blood thinner. Sometimes they have heart problems, so they are on aspirin, they are on Plavix and all the other things. So we need to stop those medications and then just observe them after the procedure so that there's no bleeding and things like that. In those instances, I usually admit them. But most of my patients are usually done under outpatient. So that is the benefit of doing minimally invasive treatments. You know that the procedure only involves inserting a needle, and the amount of tissue damage from the procedure is very minimal. And because I do it under the CT scan and on ultrasound, I'm able to evaluate all the other structures around the nerves, being the vessels, the spinal cord, and the bones and the tissue. So my risk of injury is also on the lower side as compared to, doing it in the, like how the other doctors, sometimes they just do it under the X-ray machine, fluoroscopy machine. So they only see the bones. So I have the benefit of doing it under the CT scan. So in that instance, for the patient's sake, actually, a lot of it can be done just under a half-day procedure, actually, as a daycare procedure.
Thank you so much. Following that, the question which springs to mind is, of course, yes, okay, so they can have the day surgery, they will go back home. How do they need to continue the medication, or do they have to do a lot of physiotherapy, or how much physiotherapy? How do you manage that then?
So actually, I work quite closely with my physiotherapy team and the rehabilitation team in my hospital. And I always tell patients, doing a procedure is only one part of your recovery. A lot also depends on the patient to ensure that they will get good, adequate pain relief. And there is some responsibility on the patient side also to comply to all these stretching exercises that I usually prescribe. They sometimes need 1 or 2 sessions of physiotherapy in the hospital, but I usually teach them some stretching exercises that they can actually comply and do at home. And medication, usually it's important to continue the medication for about 3 to 5 days after the procedure, and then we slowly taper down the pain medication. And if the patient usually complies to all these, they have a very good experience in their recovery, after the procedure. And usually I only see them 2 weeks after their procedure in my clinic, and usually they are already much better. So for us pain practitioners, if we can reduce the patient's pain scores from by 50%, it is considered a successful treatment. And in my instance, if you get 100% pain relief, that is actually a bonus, so I tell patients that also to manage their expectations. So they are all expecting 50% at least, and when they get that 100%, they are very thankful, that the pain is almost gone. And I have to say, the ones that I only have about 20% of patients who have some pain relief, but it's less than 50%. Patients still feel some satisfaction, but on my part, I don't feel it's a successful treatment because it doesn't achieve the 50% reduction. And usually in those instances, then we have to be slightly more aggressive in the physiotherapy and the other recovery for the patient. And usually they do get even more pain relief after that, So,
sure. I mean, as clinicians, I think it's all about managing expectations, isn't it? Correct. Like the way you said is 50%, and it only can get better from there. So,
correct.
So that's a very good thing. So now you said that how you're going to manage pain afterwards, or how much relief they will get. How, or is that possible to prevent from pain recurring later on?
Okay. So that's an important question, actually, because when we start off with pain, there is usually a reason why the patient has pain. And like you say, I'm actually seeing a lot of younger kids, teenagers in their 20s, actually, who are coming with very severe neck pain. And once we actually have investigated thoroughly, and we realized that because with the advent of all these gadgets that they are looking at, they have very bad neck posture because they are always looking down, bending down and looking at their phones. So it causes a lot of stress onto your neck and onto your lower back. They're lying down in bed, looking at their iPad or watching a movie, so that it is not ideal for all these things. So all these things affects the patient's their back health, their neck health, and these are the patients who are actually more at risk of developing slip discs, of developing cervical spondylosis, of developing muscle spasms in their back or in their neck, and sometimes even bad posture can also affect your back and your neck health. And I think because of COVID, everybody has been working from home. So my advice to them is that please make sure you have a proper workstation where you're working from home. You shouldn't be doing it on your bed, for long hours, especially when you need to review an email or reply emails and things like that. You should have a proper workstation, where you have a good chair with proper lumbar support if you're going to be there for long periods of time doing work in front of the computer. And I think the other thing is that when you also need to have proper posture when you're lifting things off the ground and also reaching for things. And I think if you follow all those rules, you can actually prevent yourself from getting injured or developing a slip disc, and usually it's very trivial thing like gardening for the older person. You sit down, you squat and pick up a pot, and that's when we look back, that is actually the source of the trauma that causes the patient to develop the slip disc. So, knowing that you need to be careful when you're doing these certain activities, then you are able to prevent all these from happening. I always say prevention is probably the best cure for any disease. And if we can educate everybody more about what it is and how to take care of their back and of their neck, we can prevent quite a lot of these diseases from happening.
Sure. Thank you so much. Yes, prevention is definitely better than cure, 100%. I'm sure you have enough experience of managing these pains for a lot of patients. Can you tell about a couple of your patients or a couple of case studies where it was managed differently and how the outcome varied?
Okay, sure. So that's a very nice question. I'll just highlight two of the cases that I always keep very close to my heart. The first patient was, like I mentioned earlier, this 16-year-old boy. He was quite a big size, big build. I wouldn't say he's obese. He's just big built, stout boy, 16 years old, 6 feet tall. Had actually a rugby injury, so he was tackled in the rugby field, and then he collapsed on the field, complaining of severe back pain. He had to be stretchered out, and when he went to the hospital, he had a very severe disc bulge. Now, I wouldn't say very severe. It was a disc bulge, but it was a tear inside the disc. And he was actually almost bedridden or unable to ambulate or sit up for easily for about 3 to 4 weeks. And when his parents came to see me and said, "Doctor, can you do something?" I said, I think they already consulted a surgeon, and the surgeon said he didn't want to operate on the disc because he thought the patient symptoms were although severe, but the disc bulge was not as severe, needing surgery. And when the parents came to see me, and I gave them this option of radio frequency treatment, so I put in a needle into the patient's disc and shrank the disc, the bulge disc that was protruding out, touching onto the nerve. Patient was actually very much well after that. The whole procedure took about an hour and a half. The patient's recovery was about a month, where the patient was quite compliant, and now he's gone to university. I just told him, you cannot play any contact sports after this, but he's actually escaped a major back surgery, and he's able to continue with his other activities. I just told him, no more contact sport. I think something acceptable to give up, to complete, his studies in university and carry on with his life after that. Maybe the other interesting case would be another 65-year-old lady who came in. Actually, she was on a stool, stood up on a stool, was cleaning the photo, or in the house, and then the stool gave away. She slipped, fell down. She had maybe some element of osteoporosis earlier on. And when she fell, she actually developed a fracture of her spine, and it involved one of her vertebrae. She went and consulted an orthopedic surgeon. Since the fracture was a minor fracture, only involving one bone, the surgeon was not keen to operate. He actually said, why don't we try conservative management? But this patient, should be the right thing to do, but this patient's pain was so severe, not relief in medication. At home, she was only lying down, most of the time, hardly unable to sit up, unable even to ambulate to the restroom. And in this instance, when she came to see me, I did a repeat X-ray. You can see that the fracture is progressing, getting even more collapsed. The height, the vertebrae is getting even shorter. And in this instance, I recommended that she should do a vertebroplasty and kyphoplasty, where we actually put in a stent into the spine to raise the spine up to reduce the amount of fracture, and also inject cement into that vertebrae. And she actually underwent the procedure, stayed only one night, went back the next day, actually walking after 3 weeks being lying down on, only lying down on bed, and there was no scar. The scar was very minimal because it's only a needle going into her spine. Of course, the stent is there, but it's no problem. You don't have to remove it. It's within the vertebrae, shouldn't cause any problem. And she was very thankful. I did see her after about a month, and she said, she's back to her normal activities. I told her, of course, knowing that osteoporosis is the cause, we also started her on her medication for her osteoporosis, to make sure that her risk of fracture, developing future fractures are reduced. And I think these are the two instances that I can recall that actually changed the patient's outcome, when they thought that the only treatment would be conservative management, just lying down, taking painkillers and waiting for the disease to heal itself.
Sure. Thank you so much, Dr. Naveen, because I think we always learn so much more from other people's experiences. So it's really good to see, what all other people experience and how they have dealt with. And, sometimes I guess in that 16-year-old boy, it's, we are forced to give up our dreams, unfortunately, sometimes. So, like you said, well, we all survive and move on. So thank you so much for that.
Sure. Welcome.
I'm going to ask one last question before we wrap it up.
Sure.
What is your advice for viewers who are suffering from pain?
So I think because pain is a very general symptom that everybody has, it's a complaint that you can get. And usually pain presents in any part of your body. I always say the danger signs of a pain is when the pain starts increasing in intensity, when it's prolonged over a certain period of time, being about a week or 5 days, when the pain then becomes, changes, the character of the pain changes, being located in one place and then goes to another part of your body. And sometimes when you develop all these symptoms, you should urgently go and seek a doctor. I think about 90% of pain does relieve with pain medication. We have very good pain medication that is available, and most of our general practitioners are well versed in prescribing all these painkillers. But if the pain does not get better after a week, even with painkillers, you should go and get yourself investigated further, because, God forbid, sometimes it could be some, a red herring, being a cancer or a fracture or a slip disc that probably is not diagnosed yet, or may not be the first thing that you think of in the initial stages of the disease. And you should not delay the treatment for all these kind of diseases, because sometimes delaying the treatment will change the options that are available for your treatment. So getting it seen and diagnosed early, you will be more suitable to undergo minimally invasive treatment. And sometimes when you do not seek the treatment early on, when the disease has progressed to a certain stage, then your only option would be surgery. So I think sometimes it's quite scary to come to a hospital, to get your disease treated or diagnosed, because everybody imagines the worst case scenario, but sometimes you have to address it. And get the treatment done earlier on, and support from the family is also very good. So I hope it's important, and I hope that people come early on to get their pain treated early on, as soon as possible.
Sure. Thank you, Dr. Naveen. I think to wrap it up, I think all what he said was prevention is better than cure, better to be safe than
Yes.
sorry.
Yeah, correct.
So thank you so much, Naveen.
You're welcome, Menaca.
So it's not yet over. Following tradition, I'm going to start announcing the speaker for the next week. It will be our episode 59. It will be Prevention and Management of Diabetes with Dr. Karunakaran Vithian. Dr. Vithian is a consultant in diabetes and endocrinology. He works as a consultant in Colchester, Essex, in the UK for 10 years. He has a passion for health promotion and has been on several public health education programs. So we are eagerly waiting what he has to come and talk about diabetes. That is unfortunately, another thing we South Asians are blessed with. So we have to, I think, pay attention for that as well. Before we take the questions, over to Kirubai Kohut to give the vote of thanks.
Once again, we like to thank all those who are on the Facebook Live. We thank you for your support, and we thank you for your patience today for the late start. Let's blame it on Zoom. We thank you. And for all those who are on the platform, we also would like to thank you for your ardent support and every week coming and cheering us on and to listen. We want to thank you. And last but not least, to Dr. Naveen, who I have met a couple of times. And thank you so much for your patience. And we finally got you on board today. And a little bit about Dr. Naveen. He treated my mother, and I loved the way he was so empathetic towards her. My mother was then 80 years old, but the way he kind of reached out to her and spoke with a lot of kindness put my mother in a lot of peace and assurance, because my mother was so adamant not to take any treatment. And I believe this is what his inherent character, to reach out to patients and put them at ease. And today my eyes are open to many different aspects of managing pain and not finally going and cutting myself, putting myself on the board and cutting myself. And that gave me much assurance. And I'm sure those on this, on the participating people here, that it is such an assurance to know there is an alternative way to deal with medicine. And once again, thank you, Dr. Naveen, for your time and your rendering of this subject. Very, very informative. We want to thank you, and may you be blessed by helping many people. Thank you.
Thank you, Kirubai. Thank you.
Thank you, Kirubai, and thank you, Dr. Naveen. So the first question which came for you, Dr. Naveen, is, are there self-care options that can supplement medication like physical therapy?
Okay, so usually, thank you for the question. So usually for patients that come and see me with any sort of pain, as an interventional pain practitioner, we usually get the patient to grade the severity of pain, and I use a visual analog score. So it's actually a smiley face score that you see on a chart, and I will tell the patient, can you please grade how severe your pain is? So it starts from 0 to 10. And I do not influence the patient. I let the patient decide for themselves how severe your pain is. And usually if the patient grades a score of 6 and above, I think they are already in the range of receiving an interventional procedure. But there are quite a lot of patients who actually said that, oh yeah, my pain was severe a week ago, but it's now actually getting slightly better, or that nagging pain is still there and it's not so severe and it's not going away. And in those instances, definitely physiotherapy, some stretching exercises, and that's when I engage some of my rehabilitation colleagues there who help with prescribing some ultrasound, some TENS, sometimes some cutaneous therapy. They give also some muscle relaxation, sometimes some deep tissue massage, and all these different therapies actually are able to control the patient's symptoms very comprehensively and adequately on top of some medications. And usually patients respond quite well to this multimodality treatment, and their pain usually resolves within the next 1 or 2 weeks. Very rarely that it progresses. Of course, there are some patients where the pain, in spite of doing all these therapies, the pain is still in that nagging number. And then I tell them and the patient is unable to go about their normal activity, then I may decide to still do an intervention procedure, or because the patient is feeling a lot of discomfort. And I do tell them, the chances of like I said, I already tell them at the beginning, 50% is a successful rate. So if I can reduce it by 50%, I hope they should be satisfied with the outcome. But most of the time they do respond with all the physical therapy and the stretching therapy that I teach them, and my other colleagues actually perform on the patients.
Sure. Thank you, Dr. Naveen. The next question for you is, what are your thoughts about guided imagery for pain management?
Yeah, so I think it is a very new field of interventional radiology. And like I said, because the technology has been advancing rapidly over the past 20 to 30 years, MRI was, the first MRI installation was only done 30 years ago, believe it or not. We have we have modalities like your PET scan, which is actually it's now a current, it's the gold standard for diagnosing cancer. But everybody forgets that the machine has come into existence only over the past 10 to 15 years. And now it's a staple for all oncology diagnosis of patients. And as you can see, the technology is progressing rapidly. The quality of the images that we are acquiring is improving. The ultrasounds that we are doing, the quality of the images on the ultrasound is also progressing rapidly. We can see what we thought we only could see muscle before. Now we're able to see bones. We are able to see nerves. We're able to see branching of the nerves. We can even see spinal cord. And that by itself explains how rapid the advancement is progressing. And we need to utilize all that imaging that we have to use it to guide us to perform safe, minimally invasive procedures. And I think being a radiologist, since I interpret a lot of these images and trained to interpret a lot of these images, I have the added benefit of using these modalities or these machines to actually guide my treatment and to minimize my risk of any side effects from the procedures or complications from the procedures. And that's why I don't usually tell patients what the machine that I'm going to do their procedure on. I look at the patient's condition, and then based on that, I will select the machine that I feel is more comfortable or suitable for the patient's treatment. And I think in the future, more and more, I think even some of the surgeons are using ultrasound in some of their surgeries, same as, some the orthopedic surgeons are using the fluoroscopy X-ray machine, this thing. Because I think doing a procedure blindly without any imaging equipment nowadays is criminal. And because we have everything available to prevent any untoward complications to the patient, everybody should utilize all these imaging modalities. And I think because of that, the rate of complications has reduced markedly since before the advent of all these different modalities.
Sure. Thank you, Dr. Naveen. The next question to you is, what is the first point of intervention for pain management?
So actually, as a doctor, as a radiologist, actually, I had to retrain myself to see patients, believe it or not. But I always say history and physical examination is the key to diagnosing a problem. And this is what when I was in medical school, this is what my professors taught me early. If you can get a good history and a good physical examination, 90% of the diagnosis is established. The other 10% is for imaging to confirm the diagnosis. Of course, there are instances where the diagnosis can be very difficult to establish, but most of the time, if you sit with the patient, take a detailed history, get them to describe what they are experiencing, I sort of already would be able to get a clue on what the patient's final diagnosis is. So at the end of the day, I think the imaging is important. Of course, imaging answers questions, other questions, not maybe the diagnosis, but if it's a tumor, whether it's involving the nerve, whether it's spread here and spread there, that is where the advantages of imaging is, and whether we are able to remove the whole tumor, or whether you decide whether the patient is for palliative care. But at the end of the day, being doctors, I think a good history from the patient and physical examination is essential to clinch the diagnosis.
Sure. As they say, ask powerful questions, you'll get powerful answers. So that's
Correct.
where the history comes, right?
Correct.
So a participant has asked this question to you. This is about a friend of mine who is in the late 60s. He's bedridden due to prolonged severe back for almost 5 years. Doctors could not find anything wrong with him by MRI or X-rays. So doctors won't do any surgery. Could this be due to stress or depression?
So the thing is that, when the patient has a severe back pain, of course, imaging is the first thing to exclude any tumor, any nerve impingement and things like that. Of course, I have encountered patients where they have psychosomatic presentation of their disease, where there is a mental aspect, or psychological aspect to the patient's illness. And that is where, when I said that I practice pain, it is a multidisciplinary pain intervention. So I work quite closely together with my spine surgeons, with my rheumatologists, with my neurosurgeons, with my rehab physicians. I even have my geriatrician also there together with me whenever we encounter a difficult case. And we should not, I'm not shy, or I'm not even embarrassed to ask them to give an opinion, because I do not want my opinion to be biased, and just to get another pair of eyes to have a look at the patient, just to see, and so that we mutually agree that the diagnosis is established, and and then we move in that direction to treat the patient. So when a patient, the other thing is that if the patient is having a problem in their lower back, if they already been bedbound for 5 years, the other difficulty we will encounter is that there's a lot of muscle wasting. Patient has lost a lot of their muscle bulk, and when they lose all this muscle tone and all that, that by itself can cause a lot of pain to the patient. You can have this fibromyalgia and all these things. So I'm sad to say that the patient, it's sad to hear that the patient has unable to get a proper diagnosis over these past 5 years, but probably visiting a center where a multidisciplinary approach for the patient would be an option, so that we are not missing something, and one person can miss something, but when 10 people look at the same patient, the chance of missing something is very, very slim. So I always say, I don't hesitate to ask my other colleague to give their opinion. And I think as doctors, sometimes we think, or patient comes to you, you think that you know everything. I think it is important for us also to discuss with our colleagues to establish a diagnosis that would have probably did not think arise in this patient, just to get so that we don't miss something for the patient.
Sure. Thank you. I know, Logi, you're waiting, and let me just finish these questions and I will come to you. My cousin had 3 injections for her slip disc in neck about few years back. She's going to get her next injection soon. Can she have any number of injections, or is there any restriction on the number of injections?
Okay, so for slip disc, usually in my practice, I usually give an injection first as the first line for my patient. And if the patient's pain is relief, then we know that the source of the pain is from the slip disc. And usually my next plan of action is to do a radiofrequency ablation. Why I choose this pathway is because usually the steroid injections, the duration of action or pain relief is usually be limited to about 6 months to a year. Most patients, after an injection, they come back and see me after 6 months saying that the pain is starting to come back, or my best patient is only been a year. Why I usually counsel patient after that for the radiofrequency treatment, because the literature says that after radiofrequency treatment, the duration of pain relief that you can achieve ranges between 18 months to up to 3 years in some cases. So when you do a treatment that can last 18 months to 3 years, you already avoid the complications of giving steroids repetitively under short duration. As you know, steroids, although the amount of steroid that we give into the epidural or lumbar or cervical region or the neck or back is very minimal, but repeated injections of steroid is not really encouraged because there are other side effects from the steroids that can develop. You can get softening of your bone and etc. So I think as long as you stick to the rule, I usually stick to a rule not more than 3 injections a year or 1 every 4 months as the maximum dose that I would actually give to a patient. But usually I've never actually reached that level before. Most of them get pain relief with a maximum of 2 injections a year.
Sure. Thank you so much, Dr. Naveen. The next question to you is, why people with osteoporosis have severe back pain? How can the pain be treated?
Okay, so osteoporosis is a weakening of the bone so it's because of the reduction of your bone density. So what happens then that sometimes they can develop microfractures and fractures that can be persistent and may not be apparent on an X-ray. So sometimes when we do an X-ray, we don't see a fracture, we say nothing wrong, but patients say they have severe pain. So I always when I encounter these kind of patients, if the pain does not get better, like I said, in 2 weeks after pain medication or oral medication, I would subject the patient for an MRI so that I do not miss an osteoporotic fracture. And the other thing that can cause severe pain is that a lot of patients with osteoporosis are usually patients who are elderly. And when they are elderly, actually the cause of the pain is not the osteoporosis. They may have some concurrent disc disease. So they may have an element of slip disc also, which probably wasn't evident or severe enough. But as they grow older, the disc bulge becomes worse and worse. And then when it starts pressing onto the nerve, then the patient has severe pain. So it may not be the osteoporosis that is causing the patient's pain. Usually it's related to the disc, degenerated disc that is causing the patient's symptoms.
Thank you, Dr. Naveen. This is the last question before I go to the live audience. There's somebody waiting for the question. Can you please explain in layman's term, injury to rectus femoris with an avulsed fragment of anterior inferior iliac spine?
So usually, your rectus femoris is actually the large muscle in your thigh. So basically, and one of the attachment is to your hip. Okay, so the top part of the muscle attaches to your hip, origins from hip, and the lower part of the muscle attaches to your knee actually. Okay, to your kneecap. So this patient, if the injury of this muscle in the ASIS is actually from the upper part of the muscle is actually avulsed or actually torn from the attachment, and the patient has a bone fragment that is flipped away from the attachment side. And this is usually the patient that I see, these quite a lot of them are like in footballers and sportsmen that actually have these avulsion injuries or fractures. Rarely happens in the older patients, and usually if it's a displaced fracture, the patient and it's separated by a big gap, then the patient will need some surgical intervention. But if it's a very minor avulsion, usually the patient will heal. But it usually takes quite a significant amount of time for the complete healing to happen. So it can take up to about 3 to 6 months. The patient usually has to be avoiding any excessive spotting activities during this time. But most of them, usually, they do not have any long-term complications from this injury.
Much for such a comprehensive answer for that. Thank you. Logi, your turn now.
Thank you. Dr. Naveen, just a quick question. I got a shoulder injury, both shoulder, because I play a lot of sports.
Right.
And my right shoulder is really, really very bad. And a couple of years ago, I was told that I need a surgery, but they couldn't guarantee me more than 50% of relief. So I postponed it. But now I got worse, and then I went for an X-ray about 4 weeks ago, and they found that I got a lot of calcium deposit. Now, I don't know how I can cure that one. I mean,
okay.
How can I get there? I mean, the pain is so bad, really bad. I mean, especially when I go to sleep in the night, just terrible.
Okay, so this calcium deposition is can be due to be, I'm assuming it's some calcific tendinitis, if I'm not mistaken. Because calcium deposition in your shoulder usually happens at the attachment of your tendon. So where the tendon actually is attached to your bone. So you have an injury there, or you have degeneration from your, like you said, your long-term sports injury. So it's micro trauma that has happened. And then after that, they healed, got better, healed, injured, and then it develops a sort of scarring at that area. And then that scarring then forms calcification. So you can actually do, of course, a surgery in an unhealthy tendon or a degenerated tendon like that. The recovery outcome is very poor, or like the surgeon told you, is about 50% only. But I think if you want to explore a minimally invasive treatment option, you can do an ultrasound, go and see a musculoskeletal radiologist. They can do a needling. I don't know whether you've done a needling technique. So sometimes what they do, they put in a needle and break up all the calcification there under ultrasound. And then they actually put in a needle or another needle, and they irrigate the joint actually. So they flush the joint with some saline via one needle, and then another needle actually evacuates that fluid that is inside the joint. So you can try that option. It is slightly painful, but they will give you medication after the procedure. And in your instance, probably that will be an option that you can think about doing.
Okay, thank you. I'll try that. Okay, thank you.
Okay, sure. Welcome.
Thank you, Logi, for the question, and thank you, Dr. Na. A huge thank you for people who subscribed for our YouTube channel for the talk show and helping us grow and help others. So a huge thank you, because I know like in the past couple of days, almost 30 people have subscribed. So thank you so much. I really appreciate that. Next week, same time, same place, we will be speaking about prevention and management of diabetes with Dr. Karunakaran Vithiyal. Until then, it has come to that time of the day for Facebook users to say goodbye. Stay safe, be happy, and keep smiling.